The last of the terrible T is very high yield. I think it's the most high yield of all of them. That's tetralogy of followed. Let's talk about the pathophysiology of this. Is that the patient may present with these characteristic symptoms, which are 4 of them. Again, tetral meaning 4, and 1, 2, 3, 4. In this case here, you have the mnemonic PROV, P-R-O-V. PROV stands for, the P stands for pulmonary stenosis. So the patient may have pulmonary stenosis, so it's harder to pump blood into the pulmonary circuit. All right, so therefore that patient may have the right to left shunting. Right to left shunting. Again, when you have right to left shunting, that leads to what? Cyanosis. Patient may have right ventricular hypertrophy, because again, the right ventricle is trying hard to pump into the pulmonary circuit and it's stenotic, so therefore they will grow in size. The patient may have an overriding aorta, and last but not least, the patient will have a VSD. It is the VSD that actually leads to the cyanosis, because if it's so hard to pump into the pulmonary circuit, it's going to back up, go through the VSD, and that sends that deoxygenated blood into the systemic circuit, and that leads to the cyanosis. Patient overriding aorta, we have an image here to show you the overriding aorta. So essentially, you can see here, this is a normal heart, and here you can see that there is stenosis here of the pulmonary vessels coming from the right side of the heart, and so it's hard to pump blood through this way. As a result, you will see blood going back this way. So deoxygenated blood will go and mix up with the oxygenated blood and gets pumped into the systemic circulation. So that's the pathophysiology of specifically dealing with tetralogy of Fallot. In terms of the etiology, the most common etiology is that it is idiopathic. It is very frequently tested, although it's idiopathic, it's very frequently tested. In terms of the risk factor, maternal rubella infection is classic, as well as alcohol and diabetes, and of course, an advanced maternal age is also very classic for that. Clinical presentation for tetralogy of Fallot, the patient may present with cyanosis early on. They may have issues at birth, and breastfeeding, or that will be a problem they will describe in the clinical vignette. Here's the star. The star is that tetralogy of Fallot is associated with TET spell. So if the child grows to be of walking age, and they're 3 or 4 and they're walking, and they precipitate TET spell, they are going to test you on understanding the pathophysiology of the TET spell. But first, we say the patient may have shortness of breath. They may have this squatting, which is basically the part of the TET spell. They may have acute hypoxia, which will lead to the cyanosis, and most cases, some cases, they may lead to loss of consciousness. So for the TET spell, so what's happening in the TET spell is that the patient is experiencing profound cyanosis, right? And so that profound cyanosis, what they're doing is that when they squat, they're effectively basically increasing the afterload. The afterload is basically where you pump against your left ventricles. So when they squat, they increase the afterload, which we assume to be here. Let's say this is an afterload. If they increase this pressure, that will lead to blood backing up into the left ventricles. If more blood backs up here, that increases both the volume and the pressure. And if the volume and the pressure increases here, we expect that blood will go back this way. So essentially what you're doing now, you're trying to shift a left to right, opposed to a right to left. Right to left means non-oxygen to oxygen, which dilutes the oxygen. But if you shift from left to right, you are only dumping oxygen in the blood, which goes into the lungs, so therefore you don't experience as much signs and symptoms. So TET spell, essentially the squatting, essentially increases the afterload, which increase enough pressure to back up blood into the left ventricles to push it back through the VSD and push it into the system, into the pulmonary circuit. That's what TET spell is, and that's what they like to test. So I would urge you to go over that specific concept again. In terms of the diagnosis for tetralogy of Fallot, like everything else, echocardiogram will be your gold standard. The pathology image is such that the patient looks like they have a boot-shaped heart. So if you look here, it looks like a boot, like they have a shoes. So boot management, we have basically you want to do open heart surgery. This is severe enough that you want to do an open heart surgery to treat it. Ladies and gentlemen, you need to just basically get the clinical relevance from all these different congenital heart diseases and make the connection. For tetralogy of Fallot, you need to understand the TET spell. What is the exact pathophysiology? Doing step 1, you memorize what a TET spell is. Here, you need to understand the pathophysiology is such that you're increasing the afterload, so thereby you're backing everything up to go through the VSD, to go into the pulmonary circuit, so therefore you have less desaturation of the blood. That's what the TET spell is. And when you talk about coarctation of the aorta, you understand the difference between the preductal and the postductal. The simple distinction, it means that if it's preductal, the collateral vessels do not get filled, so therefore cyanosis happen. If it's postductal, the collateral vessels will get filled. You'll have less cyanosis, but you have high blood pressure in the upper extremities compared to the lower extremities. So essentially what you're doing here is that you're taking all these little connections and you're trying to put it into its clinical relevance. That's congenital heart diseases.